Welcome back to Ageless and Outrageous. Today, I'm excited to speak with Dr. Kristin Vaccaro, who is a double board certified and fellowship trained urogynecologist and sexual medicine specialist. She's been in practice for over 20 years. She is an associate professor of gynecologic surgery at the Uniformed Services University in Bethesda. She recently retired from the military, where she was the program director for the Urogynecology Fellowship at Walter Reed. Now, she practices at the offices of Dr. Rachel Rubin, located in Bethesda, Maryland. She is also involved in multiple national medical committees and has extensively published in medical journals, medical textbooks, and online. She is the medical advisor for the Sexual Health Education Plus Foundation, which is a nonprofit organization that supports women's sexual health through research, education, advocacy, and grant funding. Let's explore her mind as she discusses the mind-body connection for optimal wellness. Well, tell me a little bit about your training and background and how you got into this space.
Yeah, it's such a great question. But briefly, I'm a urogynecologist, similar to you. So did an OBGYN residency and then did my fellowship in Cincinnati with Mickey Karam, which was amazing. And I actually had a faculty that was also interested in sexual dysfunction in my fellowship, which I feel like was really hit or miss in the earlier 2000s. I feel like it wasn't kind of mainstream. So that was cool. So I got a little bit of, female sexual dysfunction, testosterone replacement, things like that. We actually were a site that trialed testosterone for women in some preclinical trials. Of course, that never came to market. Long story there. But so I kind of got a little touch of it and kind of got excited in my fellowship. And then was a military provider. I just retired from Walter Reed. I was the fellowship director there for urogynecology. And I tried to bring a little bit of that in, right? But it's not conducive, long appointments and things like that to really getting into deep diving into sexual function. So it set me back a little bit. So I think and I think maybe we'll talk about it, but I sought out another training opportunity for myself. So right before I retired from the military, I did a 3-month sexual medicine fellowship, which was just absolutely amazing. It just blew my mind. All the things that we as gynecologists and medical providers don't know, don't talk about, don't discuss with our patients that are huge quality of life concerns. So, so I loved that fellowship, and I think we'll maybe get into that more. But.
Oh, definitely. It's such an area that physicians are not educated on. It's glossed over. I mean, maybe you sort of hear a little bit about some sexual function in GYN or in Urogyne, how the pelvic floor is related, but it's not a deep dive at all.
Not a deep dive. Yeah.
Right. Sure. But patients want the information. They want to have a better sex life and a healthy sex life. And so when they find someone who even asks the question, they grab onto that and they're like, oh my gosh, someone is interested. Let me talk about it.
Absolutely. I 100% agree with you.
Right. So obviously, as urogynes, we're always talking about the pelvic floor and all of this pelvic floor is amazing. I am humbled by it all the time. But tell me a little bit about how you feel the pelvic floor functions in sexual function and how important it is.
Yeah. So I think if we're talking about just the pelvic floor musculature, I'll just start there. This huge big bowl sling of muscles that a lot of women, never even think about until there's a problem, right? Just like our whole bodies, like nothing is the problem until it's a problem. But these muscles are either able to relax and accommodate penetration. So if we're thinking that, cisgender heterosexual partnerships here, able to accommodate penetration or they're not if they're too tight. So again, muscles that are too tight or painful, it's difficult to accommodate penetration. And then they also have to contract appropriately to allow for blood flow and engorgement, more sensation with penetration. So if these muscles are not having a full range of motion, and sometimes I use the analogy, you might do this as well, if a bicep, right, a full range of motion, so women can understand if the pelvic floor is chronically in a contracted state, it's hard for it to do what it's supposed to do. or if it's too relaxed and doesn't have any muscle strength, then it's hard for it to work too. So sometimes use that analogy when I'm talking about the pelvic floor and how it functions, and it supports our bowel and our bladder and the vagina and all the things it needs to do to have the pelvic floor function properly. So I often, when I'm talking about that, I'm also trying to get them to see a pelvic floor physical therapist who are magicians in the pelvic floor for any pain disorder, or just again core musculature, because it's really hard to teach a woman in a really short visit how to contract their pelvic floor to make sure they're doing proper Kegels or pelvic floor muscle exercises, but they're super important muscle group. And I think we don't, again, focus enough on, in general, the pelvis in women or the pelvic floor. And then, of course, we could talk about how, bladder leakage and bowel leakage and other dysfunctions of the pelvic floor organs themselves can affect negatively sexual function. Of course, if a woman's having any sort of leakage, that's going to usually negatively affect their feeling sexy. Again, if there's any problems with the vagina, either vaginal dryness, or fear of recurrent UTI because of sex, again, all these concerns are always brought up in my patients about, anything related to their pelvis and pelvic floor.
Right, absolutely. And, leaking urine women are not happy with in general.
In general,
leaking during intercourse is really distressing to them.
Yes. Right. Nothing less sexy, unless we're talking about squirting, which is a whole nother podcast, I'm sure.
Right.
Yeah, right.
Right, not that. That is not the topic. Right. But, and fear of leaking, if they feel like they leaked once during a sexual activity, then they're going to have that worry, which unfortunately is going to lead to them to tighten their pelvic floor, which now causes secondary issues of pain and difficulty during sex. So it really
not to mention not being in the right headspace of pleasure, and then they're in a headspace of fear, which just means you're not enjoying the experience, which is really hard for women to get out of the fear of either they're going to leak or something's not right, or their body image, or et cetera, right? Right. So a lot of women, unfortunately, aren't in that pleasure zone. They're in the worry zone or pain zone, which is not a good place to be.
Right. And our muscles' natural response to worry or history of pain is to tighten up, which is the opposite effect of what we want happening for them during a positive sexual encounter.
Totally. And again, I love analogies and stories. It's like the pelvic floor. Again, and I use another analogy of just like if there was a neck injury, right? And then the muscles just start lifting and guarding. And then over time, it's like the muscles themselves become the pain source. And it's like, how do we, get those muscles to relax? Again, deep diaphragmatic breathing, getting them to pelvic floor PT. But all these things are a lot of work and effort. There's no like really quick fix. Maybe pelvic floor Botox, but that's again for another maybe discussion. But like how do we get these muscles to relax, and then how do we get them to contract appropriately and have a good range of motion? I think it's a lot of work for women to do, right?
It is, yeah. And I think, everyone wants a quick fix or just give me a quick pill and it will take care of it. But many times by the time we see women, they've had not just days or weeks of pain, they've had years of pain. Right. So that's such a great analogy, the neck pain and the shoulders coming up to protect it. Well, if those shoulders have been up for years, they're not just going to drop in a day or two. It's going to take a lot of work, and partnering with your patient and getting her to understand this is a journey and I'm going to take it with you, and it's not going to be a short journey, but that's okay. I think even just letting them know that they have a partner on that journey is reassuring.
Oh my gosh, 100%. I think these days, I think medicine is a little bit failing women, and they feel like they don't have a good partner, right? They need to have that like provider that's going to like continue to follow them and help them through this journey. So I appreciate you saying that. I think that's a huge thing for women to feel like, what, someone's listening, someone's validating my concerns, and someone is helping me on this journey. And I think as urogynecologist, we know that really well because we're all about quality of life. I find that a lot of women are getting gaslit in various different ways these days, and it's nice to have a doctor in your corner. So.
It is. And that's something I tend to say at the end of a visit. This is the next step we're going to take. And there might be a lot more steps, but we're in it together. And
Yeah.
it's just really, really reassuring. And you can just see their faces relax and like
Yeah.
it's, and then they become much more open to the fact that it is a journey and it's okay that it takes a long time or it may take many interventions to get them to where they want to be because they know you're not going to leave them along the way.
Yeah. 100%.
Right.
100%.
Yeah. So, of course, it's not just the pelvic floor, but the pelvic floor works in our body where we have hormones and blood flow and nerves, and it's a whole complex network.
Mhm.
And certainly not every patient needs to have each of those pieces of the network addressed, but we know that hormones are a huge part of that network. So let's talk a little bit about hormones
Yeah.
or testosterone specifically, because hormones is way too general. Testosterone specifically affects sexual function and the pelvic floor.
Yeah. Oh my gosh. This topic I think we could focus on for forever. But um, if you just to set the stage about testosterone, because I think there's so much misperception about it. I think people are fearful, even men sometimes are fearful of testosterone. They think it's like, only for bodybuilders, or there's this negative connotation with it. It's a controlled medication. So there's this like fear of like, well, why is it controlled? It must be dangerous.
Mhm.
Somehow we have made men and women afraid of something their body naturally makes, which is like, what,
Something we're all born with.
right? And the crazy thing that I actually didn't even learn until a few years ago when talking with other urologists who deal with testosterone all the time is women have more testosterone than estrogen. And it's like literally my mind wanted to just explode. I was like, well, what do you mean? Like, I was never taught that. That's like a foreign concept to me. Um, and I think what's confusing for practitioners as well is testosterone, the units that are given back on a lab report are in not the same units as estrogen. So if you just look at the numbers, it looks like testosterone is lower. But then if you convert the units, it's like, oh my gosh, no, it's actually like by tenfold, 100-fold different. So it makes testosterone actually our more dominant hormone throughout our lifespan. Men have 10 times more than we do. So it's kind of like, okay, no, it's a male hormone, but really, no, it's a human hormone. And we have it too. And I sometimes tell my patients, like, estrogen is also a male hormone, meaning men have more estrogen than women after menopause, when women make zero almost. So it just kind of helps them realize that these are all human hormones, and they're not just for one gender or another. So to your question, testosterone receptors are all throughout the pelvis. So just like in men, the pelvic floor, the genitals are very androgen sensitive. In fact, the area of really heightened androgen receptors is right around the opening of the vagina, called the vulvar vestibule, which another just kind of weird, interesting thing is that is the same as the male urethra. So if you look at embryology, which again is like so crazy, how our genitals are all sort of the same, just look differently, a little bit rearranged, but they're all the same tissue. It's the same. It's the same tissue, so it's very, very androgen sensitive, right around the opening of the vagina, which is why we know that women that have taken oral birth control pills or oral hormones for pregnancy prevention, a lot of times have a high risk factor of having pain right around the vestibule because um, birth control pills lower testosterone by a complex mechanism. So it makes sense because again, it's like starving the tissue of the hormone it needs. So women again will need either topical or full body replacement to help heal that tissue. There's also testosterone receptors in the vagina. There's testosterone receptors in the clitoris. Again, we could talk forever about the clitoris too. But again, these areas are very hormone responsive. Testosterone and estrogen is all over the pelvic floor and the genitals. So when women and men age, in the late 20s, even testosterone starts dropping off, and it just continues to decline. Takes like a pretty big hit in the 30s too, and that's when libido starts declining a little bit. But it's not until most women hit menopause that things get really wonky, and then we have this intersection of like both hormones declining at the same time that is just like a crazy hit to usually for women and libido and other changes that are happening to their body. And that's generally when women come in seeking treatment for low libido, arousal, orgasm concerns, because again, they're just not getting the hormones that their body is naturally making anymore to support their genitals and their brain, meaning, how we feel, libido is a thought,
Yes.
more than a genital tissue issue. So hopefully that puts it a little bit in perspective. Certainly it's all about blood flow and supporting the tissue, the nerves, et cetera, just to make sure everything is functioning properly.
Oh, yeah. Oh my gosh, that's so much to unpack. And that's something, imagine trying to go through all of that with your
Yeah,
patient in a very
so
short
hard.
visit. You're never going to hit all that. But your first point that both testosterone and estrogen are human hormones and they are
Hmm.
not gender specific is so critical. And I think that message is trying to get out there. But
Yeah.
I agree. I think until you start to really take extra time outside of traditional medical training and
Hmm.
study this field, you don't see those differences where
No.
our women's testosterone levels are 100 times higher than estrogen at any
Mhm.
given day in
Yep.
their life. And
Yep.
imagine if we took this hormone that is present throughout our entire adult life
Hmm.
and start, taking it away. When you look at the receptors from head to toe, that means women are going to feel changes from head to toe,
Hmm.
as
Absolutely.
are
And
men. Um,
yeah.
and then the second thing I think that you said is that declining testosterone that even starts before menopause in, again,
Hmm.
both men and women. One of my favorite things to say is a lot of the symptoms that people attribute to aging are
Hmm.
really waning hormone symptoms.
Oh, 100%. Like the meno belly, like all the changes, the shifting. And, women are constantly telling me, like, I'm crushing at the gym. I'm like weight training like crazy. I'm like, why can't I keep muscle in my body? Why do I keep getting more fat in the midsection? And it's just like, we have this like collision of like lowering testosterone and then also the, terrible sleep with perimenopause symptoms and all these things, right? And it's just this like really nasty, like Swiss cheese. All the holes are just lining up perfectly, where it's just like women are feeling miserable. And it's from hormonal causes
Right.
that we can help with, if they're open to consideration. I think that's the biggest leap, right? It's like, what are women afraid of? How do we address their fears so that we can get them the help they want? Because I have so many patients coming in seeking treatment, but they're afraid. They're like, they've been told hormones are scary. There's still this prevalent fear of hormones. And it's just really, again, I feel shameful that we've made women afraid of something their body naturally produces. It's like, we're not afraid of giving back thyroid hormone. It's a
Oh,
human hormone. We're going to give it back to women and men forever because, again, like if they're low in thyroid, we're going to give them back what their body's making to support their body. But for some reason, when we talk about sex hormones, it's like, well, no, we can't do that. That's like, kind of crazy and dangerous. And again, we've made people afraid of their own biology. And it literally blows my mind every time I think about it, how
oh,
we've just treated um, this biologic function.
no, I agree. And I love that thyroid analogy as well. I use that a lot, that if you had a thyroidectomy, you would be getting thyroid replacement in the post-op
Forever.
recovery. We would say, we don't
Totally.
want you to be without thyroid hormone for
Yeah,
1 moment. Or if you
exactly.
look at the flip side of that coin, you could live without your thyroid and without those attendant thyroid hormones, but you would have a horrible quality
Miserable.
and a
Yes.
shortened lifespan
Yes,
due to the
exactly.
lack of that critical hormone. And yet we let the entire population live horrible lives and
Yes.
shortened lifespans because of the lack of their normal hormones.
And Kristin, I don't know what it is. I've obviously been thinking a lot about this lately. What is it with women and suffering? I feel like, again, society is just like, we love women to suffer. Suffering is supposed to be just a part of the life. It's like pain with periods, heavy periods, pain, pain, pain. And then with procedures, like, again, we've traditionally not given women adequate anesthesia and pain control during procedures. And then it's like menopause. It's like, nope, like, let's just suffer. So I don't know what this, we need to change as a society this idea that women are supposed to suffer. And then again, also like, how much suffering does a woman need to have until she can have a treatment, And again, this has just recently clicked for me because I now have urology partners in my practice. And, you know, a man comes in for a kidney stone. They ask about the kidney stone and they're like, well, how are your erections? How's sex?
Yes,
How's your
immediately.
libido? Like, they're not even coming in for these questions, these things. And they're like, validating anything that could potentially happen to a man. in the sexual realm. And we, you know, hardly ever talk to women about their sexual function or ask about it. And then if it comes up, you know, we usually, and I'm just generalizing here, dismiss it or undertreat it. So I think, again, in medicine, I'm actually giving another talk to my medical school later today, where I'm going to talk about all these things. We need to change it from the ground level, from the medical school, and stop being okay with just women suffering. Like, let's validate their symptoms. Let's offer treatments that are effective, and also not just effective for their quality of life, but also like improve their quality of life, reduce their need of, you know, cardiac stents and other treatments for dementia and osteoporosis fractures, like all the things that we could actually help them prevent if we were considering menopause hormone therapy. So I think we're really missing the ball in how we treat women.
I couldn't agree more. I think that's so prevalent in all fields of medicine, where if a man presents with a pain symptom, it's immediately validated. Okay, you have pain. Let's take the next step to treat that pain. And women get asked questions, well, how bad is it? And are you able to work? And is it disrupting your life? Well, she's in the doctor's office, so it must be doing something.
It's clinically relevant. She's here. She made the appointment.
That's right. She's here to talk about it. And she doesn't want to just discuss her pain. She wants to resolve her pain.
She wants treatment options, please.
Yes, she wants to get rid of her pain, get to the source of it, and improve her life. And then the sexual function as well. I actually accompanied a family member to a urology appointment, again, talking about prostate, where the male patient was steered away from surgery. They said, no, you don't want to consider surgery because it might decrease your erections. Immediately, sexual function was the first thing.
Number one.
You don't want this because it could negatively affect your sexual function. And I thought, when have we ever talked to a woman and said, hey, we're going to give you this antidepressant, but it might kill your libido?
Yeah, totally.
Do they ever even hear that?
Oh, Kristin, or they're coming in for menopause symptoms and they get an antidepressant. Because
the opposite, yes.
Yes, it is an FDA approved therapy, but it shouldn't be the first thing that we reach for. It's just, to me, that just tells women, you're crazy and we're going to give you the crazy medicine. And I'm sorry that you're now in the crazy zone. It really frustrates me because, again, this is just biology. It's just, we need to support or at least offer and consider hormones as first line, not as, the last possible option.
Right. And I think it's the same fear of those hormones. I always think it's kind of hysterical. When people are fearful of hormones, they'll say, well, don't take too much because, it might cause cancer or it might cause stroke. Yeah. And my feeling is, wait a minute, you think something causes cancer. So instead of giving them a lot, you'll just give them a little of something that causes cancer. Like, I'm sorry, do we give them a little arsenic or no, none at all? If something is harmful, we shouldn't give it at all. But if something is not harmful, then we should use it properly.
Absolutely.
But that's kind of that underlying message that you get. Right. Well, just use a little because I don't want to increase your cancer risk a lot. I just want to get you out of my office by having you stop complaining about what you're talking about.
Yeah, no, totally. Or the corollary is like, well, we might give it to you in a little bit, and then we're going to take it away, even if it works really well in a few years, because we don't want to. It's like, I'm so glad at least some of those changes have fallen by the wayside. I think the Menopause Society now has some pretty strong statements about no need to discontinue hormone therapy now after a certain age. Again, this was like all arbitrary anyway. So at least like there's been some headway, but man, and I'm sure you were there too, when this Women's Health Initiative study came out in the early 2000s, and it was just like a terrifying time for women and providers. It was like, what's going on? And so many women were taken off of their hormone therapy because of a study that, of course, now we all know has been debunked, but it's still wreaking havoc. And still, I think that prevalent fear of hormones that's still there, sort of like mesh, still that's like, oh, it's a fear. And then we have to like talk through all the nuances of that. So it's hard in society to take a thought out of collective consciousness once it's there.
Right. So. It's true. And I think some of it will be newer generations of women who are
Hmm.
not going to be accepting
They're
of
not going to
the
suffer.
same, right, of the suffering
Yeah.
that their generations in front of them did. So,
Yep.
our grandmothers and mothers suffered quite a bit. And I think our generation is starting to say, wait, do we have to deal with this and feel
Right.
horrible all the time? No. But I feel like the generations behind us are going to be like, no way, I'm going to
Yeah.
demand the proper care. And I'm
Right.
so glad that menopause certified providers are there. And hopefully
Yes.
we're continuing to grow and get this message out and hopefully to younger patients so that they will know as they approach their 30s, 40s, and beyond, this is not the way life needs to be. And you can
Yep.
make it better with something very natural
Yes.
and very
Yes.
safe.
The most natural. Yes.
The most natural. Exactly. Yes. Which
Body identical. The most natural. Yes.
right. But I mean, then we, of course, do need more research and data on it.
Oh, for sure.
We give patients actual information and evidence-based information. I mean, I know that you and I use these medications all the time, and we know there is a huge volume of
Mhm.
information we can give to patients, but there's still a lot lacking.
Yo, 100%. 100%.
Yeah.
I agree.
So
Yeah.
when you're approaching testosterone treatment with the
Mhm.
patient, how do you talk to her about the safety and the benefits?
Yeah, that's a great question. Certainly, right. The first thing I want to tell her is I don't want to get you in the male zone, right? I want to use testosterone to keep you in the female physiologic zone when you were like, you know, early 30s, feeling wonderfully vibrant, had a lot of energy, had great libido. It was easy to work out. You felt strong, all those things that you were feeling, right? Earlier in your life, that's where I want to get you back. So I do follow the clinical practice guidelines from ISWISH about, checking a baseline testosterone level. And I check a total testosterone, I check a sex hormone binding globulin, and I calculate the free androgen index just to like give me a starting place to make sure we know that, again, we're, treating a woman that actually has low testosterone and have a baseline. And then, of course, I follow those levels usually like 6 to 8 weeks later just to make sure, again, we're keeping her in the female physiologic range. So I explained this to her. I think women want to know, like, I'm not going to turn into a man, right? I'm not going to like start, having a ton of facial hair and voice changes and like, none of that, right? So we talk over that. I do let them know, though, for women that are starting on testosterone, it is really common to start getting a little bit oilier skin and potentially a pimple or two, right? And when they're starting, because again, their body has been depleted of these hormones, and it's like the body's a little bit waking up, and it's like, oh, I'm doing that again. It's like oil production and like a little bit of clogged pores, and I just let them know, like, it's okay if it happens. Generally, that goes away. Your receptors are just kind of waking up, and usually that settles once we get you kind of receptor saturated, et cetera. Um, Women, I think, are always concerned about their hair. Like, oh my gosh, please, I can't have any hair loss because, again, generally in this time frame, women might be having been huge swings in their estrogen and having hair loss. So we talk through that. And generally, what I say is, as long as we're keeping you again in the physiologic female range, we're not going to cause any sort of hair loss that's related to, like, again, male pattern, baldness, et cetera. That's like, again, really high levels of testosterone. But again, I always let them know, like, it's always a possibility, especially if you're using way too much. That's why I want to keep you in the physiologic range. So if there's any concerns, I do have them reach out to me. But in general, right, this is a physiologic body identical hormone. So generally, there's not any side effects above what I mentioned: oily skin and a pimple or two, kind of like, think like horny teenager sort of concept. That's basically what we're starting to recreate once, and then again, once we get saturated and it levels out to a steady state, that those things go away. In general, 4 months later, libido comes back. It does take a while, though. I think that's another thing with testosterone is it's not like, just flipping on a switch. It takes a little while for the receptors, especially in the brain, to kind of wake up and those thoughts and fantasies come back. So I tell them to stick with it, like just stick with it. There is no FDA approved product for testosterone in the US. There is one in Australia. So again, it's not a safety issue. And in fact, that study I mentioned when in my fellowship, we had 5 years of excellent safety data on women using testosterone in these clinical studies. And the FDA said, I'm sorry, I think we need 5 more years because we don't have quite enough data. Again, we're talking about women here. We need it to be really safe. So whatever, so it didn't come to market, but we had great safety data. And again, it was very effective. So we need to appreciate that there is not an FDA approved product, but that doesn't for women, but that doesn't mean we can't use male FDA approved products. So in my practice, we use a male FDA approved product. We just dose it for a female. So we use generic testosterone 1% in the tubes, and have a woman use a tenth of the amount. A man would use the whole entire tube per day. Sometimes it's a little tricky to dose that out, so we have them use a 5 ml syringe if it's very tricky. And again, this is like a topical gel, not an injection. And most women do great with that. And again, the nice thing is it's also very inexpensive to get testosterone gel generic. So that's also a nice benefit. But then, of course, there's compounded creams, right? If there's no FDA approved product for women, this is where compounding is also a nice way to do it. So compounded creams. Again, it's still important to follow the blood levels to make sure, again, they're staying in the right zone. I'm not a huge fan of pellets, but pellets are another option. Again, I think women are so in need of just any hormones that they'll go anywhere they can get help. And certainly pellets are convenient because it's like they work for several months at a time. I wish they were FDA approved for women. They're approved for men. So I just wish that we had I wish we had a better option for women. Right now, we're still kind of in between using a female dosing for an FDA-approved product for men, compounding, or pellets. Hopefully, one day we'll get somewhere.
Yeah, I definitely hope so, for sure. And it's, I think one thing that a lot of people may not know is you can't patent a natural product. So body identical testosterone, body identical estrogen, no pharmaceutical company can own the patent for those because it's already in nature. And in order to own a patent, they have to change it or make it unique. But what the lesson has taught us from WHI and on is when we start changing hormones, they do some of the things that the body identical hormone does, but then we get potentially things we don't want or things we aren't even aware of. So that's where when we get into the synthetic version of hormones, we have to be cautious because those are not comparing apples to apples, bioidentical hormones and synthetic, even though there are synthetic versions of estrogen, at least, and progesterone, that women can take.
And I love that you said that. I think, again, everyone lumps estrogen, especially, right, all in one bucket when there's synthetic and there's literally body identical hormones available. And then there's, slightly modified hormones again. And it's very confusing for women to know what they're getting. It's like all estrogens aren't the same, just like, all fruits aren't the same. There's apples and bananas and, but we lump them all together in one bucket and they're totally not one thing. So again, the FDA insert for vaginal estrogen, which is a very, very, very safe product, has a black box warning for, when women pick it up from the pharmacy that talks all about, cancer and dementia and stroke. And it's really scary. And there's never been any evidence for that. But again, it's a class labeling where every estrogen product got this warning put on it. And they're not all the same. And it is hard, though, for patients to understand all this, right? It's very difficult, challenging.
It's a lot to sift through, and that's why we need specialists, because you need to keep up with all of the information on all the different products. I mean, even in my training, when I graduated medical school and started practicing, I absolutely did not know all these differences between the hormones. And I just kind of thought, hey, this is the main one we prescribe. Premarin certainly was very popular. And, there was a patch called Prem Pro, and that was more convenient, so I was thinking about convenience for my patient and not about the molecule I was putting in their body. And now, 20 years later, we know so much more. And that's the point. Medicine advances, science advances, and we know more than we did 20 years ago.
Yeah. And Kristin, I think that's another great point you brought up is, as physicians, we don't just stop learning after medical school or residency. You have to keep learning and keep being curious and keep getting extra training. But unfortunately, because menopause has been like, no one has owned this midlife health section, is kind of very random who decides that wants to get more information or wants to be menopause certified provider, et cetera. There was a study that came out that only 7% of physicians felt comfortable addressing any sort of menopause midlife care for women. And that is really shameful when we have a population of 50% of our population is eventually going to get to menopause if they live to that age. And we need to again reanalyze how we are treating midlife women and prioritize their health. So.
Right. And I think that it's okay if physicians don't know how to
Mm-hmm.
practice menopause medicine. I don't know how to practice cardiology or
Right.
neurology. And I don't think of that as shameful. I just tell my patients that's not my area of expertise.
Yes.
I might have a little more general medical knowledge about those conditions than you do,
Mm-hmm.
but I'm going to send you to someone who has dedicated their life to learning about that.
Exactly.
And so I would just hope kind of the same respect from our colleagues.
Yes.
If a menopausal woman says, "Hey, I'm suffering and I'm having all of these symptoms that we know are so related to menopausal transition," for that physician to say, this is outside my area of expertise.
Yeah.
I'm not going to weigh in on the benefit or risk of hormones because
Yes.
I don't have the knowledge. That's a much more fair statement than just saying, maybe you shouldn't take them. They might be risky. I'm not
Yes.
sure. Well, if you're not sure, get them to someone who is very
Yes.
confident.
Because planting that little seed, even with the word might, is
Yes.
like for a woman, like, nope, it's dangerous, right? And I say this often when I'm teaching is the things that physicians say to patients are really important. They will hang on to your words forever. So make sure what you are saying is founded in evidence and, not like these mights and maybes, and especially again when it's not your area of expertise. Just like you said, I think also in medicine we could use a little humility, like we don't know everything, and that's okay.
And that's
But
fine.
each provider has dedicated their life or their career to treating this X, Y, and Z, and let's get you there so you get the best care you can get. So
Yes.
I totally agree with you.
That's such a great message for young training physicians or new physicians, because I'm sure we've both heard patients come in and tell me almost word for word, well, my
Mhm.
other doctor said, and then they give
Yep.
me an entire monologue, and I'll think, oh my gosh,
Yeah.
just like you said, these patients are listening, they are hearing your tone.
Hmm.
Even if it's not the words you say, it's how you say it. If you have
Exactly.
a big hesitancy and you take a big pause or a big sigh, well, hormone,
Yep.
you can use them. I'm not saying you can use them, but I mean, my goodness.
Right.
So
Right.
all of that body language, and it's important as physicians to understand that how we interact with our patients, words,
Yep.
body language, tone,
Yep.
all a part of the
All
care.
of it matters.
Yeah.
100%. 100%.
Exactly.
Yep.
Yeah. So we talked about obviously if patients have issues with the pelvic floor, too loose or too tight, they might have
Hmm.
issues with sexual wellness. That needs to be improved. If they have hormone loss, which every woman is going to have hormone loss as we get older, that needs to be improved. Is there anything women can do on their own? Because I'm sure you also hear about, I want to be all natural and I want to do things all naturally.
Yeah.
I mean, I know my answer for all
Yeah.
natural, but I love to hear everyone else's answer to this very
Yes.
popular question.
Yes. I approach this with a little bit of cheekiness. So I ask them if they drive a car, if they wear clothes, if they wear glasses, if they wear shoes, because it would be natural to be naked and walk around with no clothing and no shoes and no glasses. And like, how natural are we talking, right? We do things, right? We have tools, we wear glass, like to improve our quality of life, to improve our comfort. And so, yes, truly being completely natural, be suffering and feeling miserable, right? But we take Tylenol and Advil when we have a headache because we don't want to suffer, right? And we do things to alleviate suffering. So I try to make it kind of analogies about being natural and kind of put it in perspective. I oftentimes again talk about thyroid because it just sort of clicks about other hormones. And then I talk about sometimes other hormones like vitamin D and melatonin, which are other hormones that we don't talk about, and those are just over the counter. Again, it's like there's all these other hormones that we have naturally in our body, but somehow again we've just reserved these sex hormones as being something scary and that we should just be natural and suffer. So I talk a little bit about that. Trying to think of how else I phrase it. Of course, I talk about, again, I oftentimes actually show the exact chemical structure of estradiol, which is our main estrogen. And I show the chemical structure of progesterone. I show the chemical structure of testosterone. And I like tell them, this is exactly what your body, your ovary makes these three main things. And if we're talking about being the most natural, we're talking about replacing exactly the same chemical that your body was making. Oftentimes, and I'm sure you get this, Kristin, women come in with a gigantic bag full of supplements.
Yes.
Right. And again, whole topic we could spend on supplements, but I think women are looking for a natural solution in supplements, but really, are those more natural than what your body is making? And how much money are you going to spend on certain supplements that are maybe going to target one or two areas, right, that you're suffering? Is it your hair loss? How many supplements are there for hair loss? How many supplements for dry skin, dry eyes, achy joints,
sleeping better,
Like, it's just like, again, the anxiety and the depression. And it's like, how many supplements? And then, of course, weight changes, right? How many supplements does a one woman need to take to sort of overcome what her body was naturally missing? So I kind of try to tell them, like, we could take a handful of medications or supplements to treat all of your ailments that's happening in midlife, or you could replace what your natural ovary was doing for you, and doing it perfectly, meaning you have estrogen and progesterone receptors all throughout your body, and they're really important to keep all of them working. The genitals usually need more, which is why we always, of course, love talking about vaginal hormones. But we need to think about this more holistically, versus, again, and I'm not saying all supplements are bad. I love certain supplements for certain reasons, but if we're thinking about natural, I do tend to try to focus women on their natural products their body was making.
Yeah, I agree. I mean, I know we both feel there's nothing more natural than maintaining your body's optimized hormone levels, which is usually when we're in our 20s and maybe early 30s, when all of our endocrine organs are functioning at their best and we are feeling great and we are generally free from chronic disease, and all of those benefits we get from youth are really proper hormones. So if we can maintain that or return to that, it really is the most natural.
Right.
And certainly if people are thinking about cost, I mean, there's a huge cost in the supplement industry.
Oh my
I also
God.
use supplements, and I have, yes, quality ones that I believe in, but you also have to think about, what do you get for your money? And whatever you're going to choose, I think you get the most bang for your buck replacing your proper hormones.
100%.
The benefit list is going to be huge. Now, it's not going to be maybe 100%
right.
all of your symptoms, but you're going to get the biggest percentage improvement using something like replacing your natural hormones versus a supplement for sleep, a supplement for weight, a supplement for hair, a supplement on like
I
that.
could not agree more.
Yeah, that's really important. But you're right. I think patients are thinking that they're doing it all naturally.
Right.
Just, mixing up this cocktail of supplements that are probably not harmful necessarily, but may not be getting the job done.
Right. And I love when a woman comes in and says to me, like, I'm doing meditation, I'm journaling, I'm doing yoga, I'm being active, like doing all the things that are good for just general health. Right. So I never want to say, like, well, don't do all those things. Like, we clearly want you to do all of those other healthy things that are just really good for your mind and body. But again, the foundation for me, after a good quality sleep, because it's like the ultimate foundation, I think, for health and wellness is the layer of hormones. And then again, it's exercise, nutrition, potentially then supplements if there's nutritional deficiencies, et cetera. But I mean, again, I think we forget about the foundation, and if we don't have a strong foundation, nothing else is going to be going well. And Yeah.
And there's data showing that those things like meditation and journaling and walking in nature
Mhm.
naturally increase the correct hormone balance in our body.
Totally.
So
Yeah.
if you want to do something naturally, that can do it. But I
Mhm.
also tell patients your organs can only make what they can make. So,
Right. Right.
your 70-year-old ovary is not making any hormones, no matter
Right.
how much meditation and
Right.
journaling you do.
Right. Exactly.
But certainly
Yeah.
we make cortisol our entire lives and our adrenal gland works our entire lives. And we can use things like meditation and music to keep that more healthy, but it can
Hmm.
only give you what it can give you.
Right.
So at some point, we're going to have to help support those organs by replacing their natural hormones.
100%. Couldn't agree more.
But and
Yeah.
getting back to that, things like meditation and all those great things we talk about, they sometimes take work. I mean,
Oh,
I am
100%.
I am definitely a
Hard work.
person whose brain is going at 110 miles an hour from the minute I'm up until I go
Mhm.
to sleep. And I practice meditation, and I will say it is hard.
It is hard. It is really
Hard to
hard work.
quiet your mind
It
if you
is.
are used to your mind always going.
Yes. Yes. It's a practice, right? I'm still trying to get there. It's a
Yes.
constant practice.
Yes.
Yeah.
Meditation. I always feel that every time my brain drifts off, I just have to tell myself that's okay. Just come
Yep.
back to here, right? That's
Coming
why
back.
it's a
Bring it
practice.
back.
Right. That's why yoga is a practice. Not
Yep.
every yoga session, you're fabulous. Sometimes you're falling on your face. And that's okay, even though you did those poses last week.
Right.
And it's about just kind of getting into that zone where you can shut everything else down and really let your
Totally.
body be healthy.
Totally.
That
Couldn't
is
agree
so
more.
great. Oh, I
Yeah.
love it. Thank you for all of your wonderful information. It's been
Oh,
really,
this has been so fun.
yeah.
I
And
wish we were closer. I'd hang out with you.
oh, I would love that. That would be great. Yes, I'm going to send you my cell number. We can chat.
Yes. I love it. I love
So
it.
tell me about your day to day. Are you in clinic most days? Are you operating?
Yeah. So, because I just retired from the military, I'm in a new practice again with two
Yes.
urologists, and our focus is mostly sexual medicine. So I would say before I retired, I would do about 10% sexual medicine, 90% urogyne, and now that is like flipped right now. So I'm building the urogyne side. So right now it's mostly clinic, and I do um, one little other thing just for public awareness that I feel like is greatly overlooked is. In our practice, we see a lot of women with um, muted orgasm, clitoral pain, delayed orgasm, and we find a ton of clitoral adhesions, which is never talked about. No one discusses. And so again, I'm doing a lot more procedures for clitoral pain and clitoral dysfunction. So in my practice right now, it's mostly clinical, building the surgical side back.
Great. I
So.
just spoke with a specialist out in Tampa. She does vulvovaginal diseases, lichen
Mhm.
sclerosis, and other
Yeah.
dermatoses. And we had a talk about clitoral anatomy and how overlooked it is. Once
Oh,
again,
totally.
even in the routine GYN exam, are you ever taught to examine the clitoris, push the hood
Never,
back, look at
never.
it? And
Right,
I will be the first to say that for many years, I also completely ignored the clitoris, kind of went right to the vaginal
right.
detritus and
Because that's what
beyond.
we were taught. That's how we were taught.
But then the more I talked to women and they started to have symptoms, I started looking on my own and
Yep.
then reading, more research and
Yeah.
finding these clitoral problems where I'm like, I can't even find your
Yes.
clitoris.
It's
No
it's
wonder you're having
amazing.
trouble.
It's I would say 1 out of 4 patients that I see now has moderate to severe clitoral adhesions. We don't ever tell women how to take care of their bodies.
Right.
Boys that have a penis are always that have a foreskin, excuse me, are
Yes.
always told pull the hood back, pull the foreskin
Love
back,
the
right?
stigma.
And
Yes.
we never tell women how to take care of their genitals. And I do believe if we did, that we wouldn't have so many adhesions. Certainly, there's vulvar dermatoses that can also put women at risk for this, but in general, right, most of the women I see don't have any vulvar skin conditions. It's just adhesions. And I'm sure, was it Jill Kraft, the one that you
Yes.
were talking with? Yeah,
Michelle,
she
yeah.
knows. Yeah, yeah,
Yeah, she's so great. And we talked about that exact thing, right? Women don't get taught about their anatomy. We know
yeah,
it's internal, but that doesn't mean we just ignore it.
yeah,
Of course, there's all the shame about it and, keeping it hidden. That's a whole separate thought
totally.
process, right? When we should, I mean, I gave the point that I'll take 50 and 60-year-old women and take a mirror out and my little Q-tip and point around, this is
Yes.
the clitoris, this is the clitoral,
Yes.
and they are in amazement.
Mind blown, right? Mind blown. Yes.
And they're almost embarrassed. I am 65 years old. I never
I
knew
never knew this.
that's
Yes.
that my urethra was there and that was this and
I
things
know.
that I'm sure for you and I, we feel like, okay, we look at it 10,000 times a day,
Right.
but
Right.
they do not look at their
Right.
anatomy and they don't know. Or the flip side, for the very first time ever, they'll look at their anatomy and they're like, what is it? Has it always been like that?
Yes, no, I think the power of a mirror cannot be understated. We also use a mirror, and I'm always blown away by how powerful that is for women, and encourage them to inspect often and frequent to make sure things are staying healthy.
Yes,
Yes.
definitely. Yeah. And I think we probably don't truly know the percentage of clitoral phimosis and adhesions because, again, it hasn't been looked at and
Mhm.
we don't teach women to take care of their anatomy. So it makes
Yeah,
sense that after a lifetime of not moving
right.
the clitoral hood, maybe it gets a
It
little
might be
stuck.
stuck. Yeah. So I'm actually really proud to say this. One of my prior fellows, we measured 150 vulvas for every single thing that could be potentially measured, and it's getting presented this month in Atlanta at Ipswich. And we found 15% of women have clitoral phimosis that's moderate to severe with all comers, meaning they're not coming in for a sexual complaint, they're coming in for an anal GYN exam, they're coming in for something else. So there you go.
So there,
Hot off the press, getting presented in 2 weeks. 15% was what we found.
congratulations. See,
And
that
that's
is real information that
all women, all ages, all genders, a really nice diverse group of women. So
that is great. Yeah, because that's the kind of basic work that we need that has been ignored
right?
for
Like,
so
how do we
long.
not know this? It's like, oh my gosh. Yeah.
Yeah.
So there you
There's
go.
actually an old study, I don't know if you've seen, where they measured in many women, the distance between the clitoris and the anterior vaginal wall,
Yeah.
and that,
Yeah.
leading to that whole discussion of why women cannot reach orgasm with
Yep.
penetration alone, or
Yeah.
when women can reach orgasm, maybe they have that shorter distance.
Yep.
It's really just clitoral stimulation during
It's
penetration that's
yeah.
happening. Um,
Clitoris. The other thing is a big thing that I always say too when I'm showing the genitals together, male and female, is basically the penis is the clitoris and the urethra.
clitoris
It's
head.
called the clitoral urethral complex. It's the same as the penis, and we kind of look at the internal structures because again, I think also women, it's like mind blown. Like what? Like I didn't know. So it's oh, it's just base. It's just the basics, and we're missing sometimes just the basic fund of knowledge.
Right.
Women, I think, feel shamed their whole life if they can't orgasm through vaginal penetration, and it's because they really need clitoral stimulation. So, yeah.
Exactly. And I usually teach it to women the other way. Say, if you were just stroking your husband's penis on the shaft and you
Yes.
never touched the head of the penis,
Yep. Totally.
I mean, it would feel nice, but you would do
Yeah.
nothing for him.
Right.
For many
Totally.
women, that's what
Yep.
penetration is. Just
Yep.
and they kind of have a
They're
light
like,
bulb moment and they're like, "Oh my gosh, you're right." And I'm like,
yeah.
"He needs to stroke the head of your penis." Like that's just
Yes.
what needs to happen.
So totally true.
You're just the same. We're the same animal,
Right.
but just with our parts in slightly different areas.
Just a little bit rearranged in
Yep.
different sizes.
A
That's
little
all.
rearranged for a different function, but we can
Yeah.
all get there if we just had a little bit of knowledge. And that, goes even back to teaching it correctly to kids, right? To younger
Oh,
kids.
totally. Totally.
Oh, when my kids were young, their school had their sex education time. And I called up the director and I said, "Hey, I'm a GYN and a Urogyne. I would love to teach your
Hmm.
kids about proper anatomy. I'm a huge fan of using the proper words, right? And
Yep.
destigmatizing the proper anatomical terms." And I said, "Let me talk to them." And they were
Yeah.
against that. They said, "No, we have this is what we're going to talk about."
Right.
And it was asking the kids to write down questions they had and answering them, and I was like,
Yeah.
they don't know what information they don't know.
I know. Well, I have a quick story. So my son, fifth grade, his family life, this was several years ago now. The very last day, this girl raised her hand and said, "Do girls have penises? Do girls have penises?" And my son, apparently the teacher tells me, my son sheepishly raises his hand like, "Oh God, I can't believe I'm doing this," right? And he says to the teacher, "Well, my mom's a vagina doctor, and she says that women have a penis-like structure called the clitoris." And I was like, that's it.
My job is done. My life is complete. My son understands.
My son, yeah. And she calls me and she's like, in my 30 years of teaching, I have never heard that before. And that was so beautiful. She's like, that was amazing. Like, you're welcome. So,
I know.
anyway,
hopefully we will have more of that.
Yes.
I'm the clerkship director for the FSU College of Medicine here in Florida. So I see all the third year medical students that come through, and I give them their weekly lectures. Obviously we have a syllabus. It's the same weekly lectures. And every time we get to the week where we talk about menopause medicine, I tell them, this is going to be my legacy. I am educating a new generation of physicians.
Yes.
Do not be fearful. And just these things, you don't have to be an expert, but you need to send to an expert. And you have to make sure that we are giving women fair and balanced information and no longer fear mongering. I said, that's going to be my med school legacy. This is my platform to get it done.
I love that legacy for you, for them, for womankind. I love it.
Yeah.
That's wonderful.
My daughter is just turned 24, and I talk to her girlfriends all the time about things like this. And I just think, I want more for them. I don't want them aging.
Exactly.
Having disease and having dementia and fracture or osteoporotic fractures. I want them to know and demand more, because I know that my generation didn't, and we just kind of did what we were told to a degree. But I'm proud of them for pushing it, and I want to contribute to that.
100%. I couldn't agree more.
Great. Thank you so much for taking time. This is really wonderful. We'll definitely have to do more about, there's so many more topics to push into. We can do one just completely on the clitoris.
Oh my gosh, I would love that. Love that.
Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.